Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
71-year-old never smoker with a history of stage 3A adeno on the right upper lobectomy, adjuvant cisvinorelbine and radiation sequentially. Then relapsed with multifocal brain, bone, liver, and omental metastases, but it was 2 years later. Found at that time to have an EGFR mutation and received erlotinib for 2 years. This goes back several years. So 2 years of erlotinib, EGFR T790M got osimertinib for 2 years. And then after that, carbo, pembro have PDL1 in the low range, not specified beyond 1 to 50%. Then PEM and pembro maintenance for 9 months. But unfortunately now with multifocal enlarging metastases, cough, dyspnea, fatigue, and some weight loss, but a performance status still in the 1 range, and no other medical history to speak of. Here is the brief outline going back all the way to 2013 after her prior surgery, a lobectomy in 2013, 2 years of erlotinib on relapse, 2 years of osimertinib, carbo, pembro, and now progression on the maintenance.
The imaging shows the post-surgical appearance of the right lung after a right upper lobectomy with volume loss, and post-radiation changes. We see paramediastinal fibrosis in the right lung, which is from the radiation. The left lung is fine. If we can move to the next slide, which will demonstrate a metastasis in segment 4B of the liver. And on the right-hand side, the arrow is pointing to peritoneal carcinomatosis. There's extensive infiltration of the peritoneum, and this is a fair amount of peritoneal burden of peritoneal carcinomatosis.
Okay, so here's the, you can see the diagnostic workup, a recent core needle biopsy of a liver mass with the molecular profile shown here, T790M and the exon 19 deletion, as well as several other mutations identified, a KRAS non-G12C, P53 as well. So Ram, what are your thoughts here? It's not for lack of looking for something to pursue after this, but this is often what we find. And this person has been, has received a lot of prior therapies.
Yeah, I think the molecular profile here doesn't show us a very obvious target to pursue in the post-OC setting. The patient's progression is not oligoprogression, it's more a widespread progression. So continuing on with osimertinib is not going to be an option. The one question I have is how long has it been, continuing on with chemo plus pembro is not an option. The one question I would have is how long has it been since the patient's last EGFR TKI exposure? If it's been 9 months to a year. Sometimes just reintroducing osimertinib in the situation may result in reintroduction response in 15-20% of the patients. So I often go back to osimertinib if it's been a while since prior exposure to see if that would be beneficial. If, on the other hand, this was just done a few months ago and this patient has progressed very early on with the chemo-pembro approach, then I would really think about docetaxel, ramicirumab as the next line of therapy, given that we don't have any other molecular targets to pursue.
It's been 9 months. So what would you say there?
I think it's worth reintroducing osimertinib and see how this patient does. 9 months is long enough for this patient to have been without a TKI, and we may be able to salvage a response in this situation.
Okay, I agree. I think 9 months is one of those half empty, half full. It's not a terrible raging progression immediately, and she could benefit from subsequent chemotherapy as well. But I think that I would be inclined to hope to do both at some point, and those are outside of a trial the leading options. Any other comments on her? If not, I'll just summarize. Cliff, you have anything?
No, just that if it wasn't for the mental involvement and they were having isolated progression of a liver lesion, sometimes we can give new life to systemic therapies if we just deliver local therapy for oligoprogression. But in her case, this is a fundamentally different degree of progression. There's no active role for local therapy.
No, and I think many of us we're all coming around to oligoprogression as worthy of local therapy, whether it's surgical or radiation, but not here. So let me just go back to her initial slide. I'd like to just summarize that in this case, I would say there's two options that the panel came up with. One, the consideration of returning to osimertinib. It's been about 9 months in total, and there is a potential that after this EGFR therapy-free interval, patients can resensitize and get some benefit. The other leading alternative would be docetaxel-based treatment that has a proven survival benefit, potentially, and I would advise, and our other participant, Dr. Ramalingam, also might favor docetaxel and ramicirumab, as long as her performance status is sufficient for that. So those would be the leading options, just really a question of sequencing. And unfortunately, the thorough molecular testing does not give us a better option, nor is local therapy a good option here.